I find that there's a real disparity between the amount of periodontal disease that we know affects our patients and our population and the actual amount of treatment that's being done. I wish that there was pain so that our patients would come to us and say something's terribly wrong. But instead, they're so used to seeing pink in the sink. They're used to seeing bleeding, and just because it's common doesn't mean it's normal. We all know that. But unfortunately, our patients don't always know that. We're in the prevention business. So I say, let's stop watching and waiting, and let's prevent destruction of the bone and the attachment. Let's prevent heart attacks and strokes. Let's prevent miscarriages, and let's prevent Alzheimer's.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 233. My name is Andrew.
And this is Michelle. And if you listened last week, I was enjoying a nice white wine from my Washington wine sent to me by Melissa. And I had 4 bottles sent to me. So don't look at me like that, Andrew.
Well, I just wonder, how many bottles are you in today? That's more the question that I have. Are all 4 of them gone?
I've been slow. I've been trying to get better about it. Because also, you guys probably remember a year ago, I had this crazy major surgery and went into the hospital, was there for like 6 days. It was like insane. Super lucky that it didn't happen in Costa Rica because this was on the back end of the mission trip that we did last year. And I am trying to figure out my diet a little bit better because I don't feel as great because, well, quite frankly, I didn't do the follow-ups that I really should have done.
For someone that's so health conscious, I am just shocked and appalled.
Well, it was not because of health conscious, like lack of being health conscious. It was because I was dealing also with my mental health of like, holy crap, that grounded me for 6 weeks.
Yeah.
I have to hustle now to get back. And so I just like feet hit the ground running. And again, somehow, even with 6 weeks being down and a major surgery, I was gone for 170 days last year. So it was a little crazy, a little bonkers. And guess what I get to have? And listen, I know this might be TMI getting into it because this is a dental podcast, but Andrew and I are pretty transparent. And we'll make probably more me than Andrew, but I get to have a colonoscopy and an endoscopy. Can't wait.
Gosh, you're so lucky, man. The things you get to do in your life, travel the world and then colonoscopies.
But, and you know, this is not going to come as a surprise. And if anybody
I get
knows
what you
me,
did there.
not gonna,
but
it's not,
colonoscopy.
but
that's good. You're so clever.
But we need the soundtrack or sound thing. Bump. I went to a really awesome GI doctor that I'm just super lucky that he is here in Charleston, but he's been on multiple podcasts that I've listened to, which was kind of coincidental. I listened to this podcast called Plant Proof. It's an Australian guy getting his master's in like nutrition and stuff. And he had Dr. B on, and Dr. B actually just finished a book called Fiber Fueled. It went out or launched on New York Times or New York's bestseller list or whatever. And so he's my doctor. And I'm like super excited that I even got an appointment with him. And so we go through all my stuff and I'm like, so how often do you like partner with other professions? Because I'm just, like I'm a dental hygienist and, we handle the chewing apparatus of all the food that you want people to eat that's really good and healthy. And so I'm just curious, how often do you work with a dental hygienist? And hi, I'm here and I have a podcast. He was like, I guess I've never really thought about it. And so we talked a little bit about that interprofessional collaboration and what does that look like. And so I'm going to get him to come on the podcast. I'm really excited.
That'll be good.
Yeah, I'm really excited about that. So you guys will enjoy that. And I just wanted to talk a little bit about that interprofessional collaboration. And we have some few things to talk about, but it kind of goes with the podcast that we have today, the interview with Kathryn, because she does a lot of interprofessional collaboration and it's how important it is to look at that person holistically. So it was really good. So I'm just glad this all worked out. We could talk about it on the intro.
Yeah. Look at that. Fate working in our favor.
I do want to talk about that zit on your face, though.
I had this transition figured out too, from Michelle's insides to Andrew's outside. My face is breaking out. Okay, so the backstory is so by the time this airs, it'll be 2 weeks or so that I've been back to work now, and we have the KN95 mask, and then we have our level 3s over that, and we have a face shield and that whole getup, right? First of all, I'm going to make you and I talked about this on the phone. I'm going to make a very unpopular declarative sentence that y'all need to quit. Cut that word out. No, cut that word out, Daniel. Daniel, we will leave you
never
guys.
Will this leave the podcast? Out. This will actually save it. Save it. Daniel, save it. Save it. Don't take this out, Daniel. I will fire you. I'll fire him.
He's gonna. I will fire him. Yes.
No,
okay, let's start again.
That stays forever.
No. Okay.
If you guys don't know what this means on the podcast, Andrew has given me crap for years that that I say y'all, and he's never said y'all, and he just said y'all.
I said you all really fast. That's the difference.
Episode 233, forever and always, are going in the history books. I will gaslight you till the end of this if you want to keep talking. You said y'all, that stays in the podcast.
Apparently, when I get really excited, I turn Southern talking to Michelle. So, anyways, you all need to stop complaining about the heat thing. That's my controversial statement that I wanted to make. Here's the thing.
Andrew, but you also have to preface this that the one thing that we have in common when we travel is we walk into a hotel room and jack that heat up to at least 76 to 77.
Sure.
A bit more.
Yeah. No, I'll definitely, the heat. I'll give you that too. But I don't love I love the atmospheric heat of the sun and the sunlight. Not so, and I guess I like being warm when I sleep. Okay. I like the warmth anyways, but I don't like, but when I'm working really hard in a dental office, I don't like to be super hot either. So it's not I'm jacking that thing up to 85 just so that I can, sweat and
be comfy. Yeah.
So here's what I've deduced, and it might be very wrong, and I'll accept that I'm probably a little bit wrong on this. Putting an extra mask on and the face shield is not going to raise your whole entire body temperature up to a time where you're like, oh my gosh, this is so hot. What I think has been happening is that people have not been wearing proper PPE, including
that's so true.
to the wrist gowns, knee length, or even further gowns that are covering their whole body. I've seen so many pictures and so many discussions with my friends who just wear their scrub top and that's it. And so that's where I think the real problem is of, oh, I'm so hot. It's not because of an extra mask or the face shield. I think it's because they're actually doing the PPE like they should be. Anyways.
Are you wearing the scrub cap?
I'm not. No.
Maybe that's wear that and then get back to us.
Of ours.
Wear it and get back to us then.
I will absolutely. I'll love it though. I'll love a scrub cap.
I'm totally fine with it. And I think, I have two comments to that. One, I think you're correct in your assessment that a lot of people probably are struggling with this because they weren't wearing all of this prior. And you and I both were. Mm-hmm. So adding the additional mask is not so big of a deal. My problem when I wore it the other day was my loops, because you're not wearing loops, right now, as you're transitioning, you're not wearing the loops, but I tried to wear my loops and I had an N95. So I didn't have the KN95, I had the N95, and that transition where the loops and the N95 came together. And then on top of my face shield, pushing everything together, there was this pinch mark across the bridge of my nose, which is just more of it's not heat, it's whatever. I wasn't really super hot. I mean, when I pulled it off, my face was a little sweaty, but I leave with marks every day from my loops and my mask anyway, because these cheekbones are giant. But the heat part is a big deal. That was the issue, was the weight of it all. But for me, that's more let me test out a few different products to find what fits my face and my head better. And I wonder if the N95 is a little bit hotter than the KN95.
It could be. I honestly don't think everyone that is complaining is using an N95, though. I feel like the majority of people are using KN95s because that's just what's available.
Maybe the majority are wearing lab jackets to go to the wrist now.
Yeah, maybe. Okay, so to get back to it, this big old zit on my face is
Is right where
sweat
it lands.
induced from the two masks and like the moisture that has been collecting on the inside of my face.
I'm glad you said moisture this time and not
It's very moist
as you
inside,
said prior, because we've
the mask.
determined way back when that moist and flappy were off your words you can use.
Wait, flappy was too?
Yes. You said, you've described flappy as like the gum tissue around some of these pockets for your patients. And I was like, I never want to hear that word come out of your mouth ever again. I can't.
I blocked that out of my memory, but that is now fresh. And
that is within
down,
6 months of our podcast.
Stephanie's name written down so I can remember to say their names.
If you say moist and flappy in the same sentence, I might shut down. My brain will melt. My brain will literally melt and I won't be able to function in the conversation anymore.
Moist and flappy.
You're real special. Oh my gosh.
Yep. And so that's the story of my broken out face. So with all of that disgusting news that you all heard from us.
Yeah. Well, if you're new to the podcast, we do this intro where Andrew and I catch up and talk randomness of dentistry, dental hygiene, and our lives in general. But we're going to throw it to the episode because we are finishing out our Perio series. Man, what some just heavy hitters and good people that really deliver a great content. So again, we had Amber, we had Katrina, and now we have Kathryn. So I'm really super excited for you guys to hear this awesome episode with Kathryn. Be sure to check her out. And again, if you have any questions, send us any info, but enjoy this episode with Kathryn first.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
So I am really excited to bookend this series that I've been dying to have. And I've said it multiple times that I can't believe it's taken me this long to have a perio series, but I'm very excited for our last interview in this series. Kathryn is one of the sweetest people I've ever met in our profession. And so I'm really excited to have her on. So welcome to the podcast, Kathryn.
Thanks, Michelle. I'm so glad to be here.
So give us your full name, tell us who you are, what you're doing, and why you love perio.
My name is Kathryn Gilliam. I'm a whole health dental hygienist. I've been practicing for more than 30 years, and I own and run a speaking and consulting business called PerioLinks. As a consultant, I work with dentists who want to elevate the standard of care and grow their practices by becoming oral wellness specialists. And as a speaker, my most requested programs teach healthcare professionals how to optimize treatment outcomes and maximize profits. I find that my clients tell me that they're seeing happier patients, more engaged team members, and a healthier bottom line. So when we do the right thing for our patients, the practice grows. I love perio. I love taking the best care possible of our patients. So I'm really thrilled to be part of this program.
So on this, or in this series, we've touched on the staging and grading. We touched on lasers and probiotics. So where do you land in, what's your topic? What's your favorite thing to talk about and teach people in perio?
My favorite thing is to talk about the specific bacterial pathogens that cause periodontal disease and how they're related to overall health. So that's what I wanted to talk about today. I love to use technology in order to better serve our patients. So that's my topic. I'm a total geek when it comes to bacteria, and so many of us are. So that's what I wanted to talk about today. I find that there's a real disparity between the amount of periodontal disease that we know affects our patients and our population and the actual amount of treatment that's being done.
Oh, that's the truth. So I am so excited. I want you to just take it and run with it. Teach us everything.
Okay. I'm going to start with my why. I'm going to tell you just in a nutshell about what started me on this path to making sure that every patient is focused on as the whole patient and not just as a set of teeth and gums. And that's because many, many years ago, my best friend, who was the healthiest person I've ever known, died of a massive heart attack. And it was said that it was of unknown causes. He didn't have high blood pressure. He didn't have high cholesterol. The only thing that we could determine was that he had periodontal disease. And so many people have horrible, horrible health consequences, whether it's a miscarriage or a heart attack or a stroke. And the doctors say, well, there's an unknown cause. We have no idea why this happened. But in many circumstances, if you trace it back, you can link it to oral pathogens. And that's exactly what we did with my best friend, Steve. So when he passed away at the peak of his life, he was in his early 40s. He had just had a complete physical, and he passed the stress test with flying colors. And the doctor told him he was in perfect health. And the very next day, he was playing basketball with his youngest son, and he had a massive heart attack and died. And that was it. As I said, I can't change Steve's story, but I can do something about the rest of the people in my life and my patients. And so that's where the journey began for me. It's over 20 years now.
Wow.
And it was such an eye opener, because you think back to all the people who have bleeding gums, and nobody told them that could mean that they were at higher risk for cardiovascular disease, or higher risk to lose their pregnancy, or higher risk for Alzheimer's, or all of these things that are connected. And I know that if Steve's dental hygienist had said, you have bleeding gums, and I'm concerned that you might have a heart attack or a stroke, he would have done something about it. He was that type. He ate well, he exercised, he was in perfect health other than that. And this is such a silent disease. We've told our patients for years, periodontal disease is a silent disease. You won't have pain until it's very advanced. You don't know what I'm seeing. And it's so true in a much bigger picture. We don't know what's going on inside the body, inside the arteries, inside the organs. But when we look further, we see terrible devastation as a result of these pathogens.
In the podcast with Katrina Sanders, where we went over staging and grading, she said, which I thought was really funny, she wishes the prostaglandins caused more problems, more pain, so people did feel it, and it wasn't such a silent disease that we all know. If we're in the dental profession, we all know that.
Yes, she's exactly right. I wish that there was pain, so that our patients would come to us and say something's terribly wrong. But instead, they're so used to seeing pink in the sink. They're used to seeing bleeding, and just because it's common doesn't mean it's normal. We all know that. But unfortunately, our patients don't always know that. And that's why I agree with Katrina. I wish there were pain associated with this disease at a much earlier stage. When we talk about periodontal disease, it's so interesting, because this comes to mind because Katrina is a full generation younger than I am. And there's a very different model of periodontal disease that's being taught now than when I was in school. But there are still plenty of hygienists who are practicing according to the model of periodontal disease that we learned 30 some years ago. So that model of periodontal disease was about how periodontal disease is an inflammatory disease of the supporting tissues that is caused by specific bacterial pathogens, and they trigger an inflammatory response, which results in the destruction of the gingiva and the periodontal ligament and the bone. And when we had that sort of more general definition, it led us to believe that we had to have those specific pathogens present, and we had no idea to know if they were present or not back then. We didn't have any technology that we do now. So we somehow developed the idea that we had plenty of time to encourage our patients to floss better and floss better. And every 6 months we were saying, we just need you to floss every day, start out twice a week and work up to it. And, we kept encouraging our patients, and we thought that we had time on our side. And then research came out, and it said that we had red complex and green complex and orange complex. So they identified these various bacteria, and that was progress. And actually, that was before I became a hygienist. So when I became a hygienist, we knew about these different types of bacteria. We still had no way chairside to identify what was happening in our patient's mouth. But we knew if we saw really aggressive disease, they probably had some red complex bacteria, but we weren't connecting all of that. We were still talking about flossing. And now there's been this huge shift. There's a new model of periodontal disease, but somehow it's not made public for the practicing hygienists who are not actively pursuing their education. And unfortunately, I'm learning as I go into more and more offices these last 20 years as a consultant, not everyone avails themselves of the latest and the greatest. They're not reading research. They're not reading journals. They're not attending all of the higher level continuing education courses for a lot of reasons. You know, whether they can't afford it, whether they don't have time, whether they have young children at home and their hands are full. There's a lot of reasons why people don't pursue the education that I wish they could or did. And not everybody is as fascinated with this stuff.
Right.
So, you know, not everybody reads, you know, PubMed on Saturday night like we
For
do.
funsies.
But, right. Right. But, you know, there is this new information, and unfortunately, we haven't made sure that everyone has shifted the way they practice as a result of it. So they are still practicing with that old model that I just described. The new model of periodontal disease is called polymicrobial synergy and dysbiosis. And what that means is that there are multiple different bacteria. And in this polymicrobial bacterial mix, we have lots of different bacteria. Some are beneficial, some are benign, and some are pathogenic. And within one single infected periodontal pocket, we have over 1 million periodontal bacteria. And as the bacterial biofilm begins to grow, its layers become more and more anaerobic, and more of the pathogens get into that soup. And the biofilm is protected by this slime layer, and it has adherence properties, all sorts of complex channels for food and waste. And this is not something that can be easily rinsed away. So that's one thing we need to assure our patients that if they do a simple swish with a commercial mouth rinse, that's not going to be effective against this really complex bacterial matrix that is developing thicker and thicker layers on their teeth and the roots of their teeth. Not only that, the second part of that is synergy, polymicrobial synergy and dysbiosis. So those bacteria that are building up work together, and they have a very complex pattern of communication. And this enables them to increase the way that they can affect not only the area that they're in immediately, but the entire host response to them. So all of the inflammation that our body mounts against those bacteria can be affected by these bacteria as they get more and more progressive. And dysbiosis means it's a state of imbalance or disease. So polymicrobial synergy and dysbiosis is a theory that is about the increased virulence of this synergistic oral bacteria and how they work together. And as they work together, the damage that they cause is multiplied. But what we didn't know for some time was how it is that they work together. How does this synergy happen? And they then discovered something called the Keystone bacterial pathogen discovery. So the Keystone pathogen hypothesis means that there are certain low abundance bacteria that are so pathogenic that they can actually shift the entire DNA of that entire microbial environment. So when we have the presence of a bacteria called Porphyromonas gingivalis, that's the Keystone bacteria that they have discovered. I have a sense that there may be others. Maybe all of the red complex bacteria will be determined to be Keystone bacteria at some point. But right now, what we know is Porphyromonas gingivalis is the Keystone. So PG, we'll call it, actually can change the DNA expression of all of the other bacteria in the mix. So while some bacteria started out as benign or even beneficial, in the presence of PG, even in low amounts of PG, those bacteria can have their DNA hijacked, and they can also become pathogenic. So now we have this extremely virulent mix of bacteria that can cause tremendous destruction in our patient's mouth and in their entire body. And PG not only changes the DNA expression of all of the bacteria, it also inhibits the host immune response. So the bacteria become more and more virulent, and the body is less and less able to fight it off. So when I learned it, it just, everything opened up for me when I learned that. I thought, oh, the lights came on. This is why we don't have time. This is why we don't have to wait for huge amounts of bacteria to build up in the mouth before it becomes urgent. We have one sign of bleeding, and even if we don't test, we need to assume that that could be a very pathogenic situation, and we need to have our patients change something. I'm not necessarily going to do full mouth periodontal therapy the first time I see one bleeding area. However, I'll address it in some way, whether it's with interdental cleaners, whether it's more frequent professional appointments. There's all sorts of antimicrobials that we could throw into the mix. Whatever it is, that's the point at which we become concerned, the very first sight of bleeding. We're in the prevention business. So I say, let's stop watching and waiting, and let's prevent destruction of the bone and the attachment. Let's prevent heart attacks and strokes. Let's prevent miscarriages, and let's prevent Alzheimer's. And I know these diseases are multifactorial diseases, and that if we have a healthy mouth, it doesn't guarantee that we won't get dementia, that we won't have a stroke. But what it does do is it reduces our risk of so many different conditions. And that's our job. And we're the prevention specialists in all of healthcare. So we have this tremendous opportunity to make a difference. And I keep thinking back to Steve. His hygienist had an opportunity to extend his life, to help him live longer, and missed that chance. And so he missed his children growing up, and he hasn't seen grandchildren, and he didn't see college graduations, and it's tragic. And so when I see someone in my chair and they have bleeding gums, even if it's one site, I started thinking about the bigger picture. What could be happening inside that body that I could cool off, that inflammation that I could help cool, that would maybe slow down the hardening of those arteries, or slow down the progression of brain tissue destruction? And who do they have in their lives that's counting on them and that would be so devastated to lose them? So it's a much bigger picture than somebody with bleeding gums who's not listening to me about flossing. It becomes, let's have a conversation about your health and your life. And it changes everything. And I really credit, as strange as it sounds, I credit reading about polymicrobial synergy and dysbiosis and the Keystone pathogen theory, because that's when the light bulb went on. I knew after Steve passed away that there was a huge connection between the mouth and the body. I really knew that actually growing up. My father was a dentist, and he used to talk to us at the dinner table about, if your mouth is healthy, your body will be healthy. So I always knew that philosophically, or in a sort of vague ether type of way.
That's interesting, because that's kind of before his time then, right? Or before the time of us understanding that. So how astute of him to have that thought.
Yes. My father was such an interesting man. That was in the 60s, and he was a physician and a doctor of dental medicine. He got his degrees at the same time. So he was a very interesting man, but he practiced dentistry, and he was in the Air Force. So during times when all of the surgeons were away from the base, he would deliver babies or do an appendectomy or whatever emergency needed to be handled. So he was a very well-rounded healthcare practitioner. And so we grew up knowing a lot about the mouth and the body connection. And then as a hygienist, I was searching for more information about that, more science. And it took me a while to find my tribe. I finally found the American Academy for Oral Systemic Health. I found Dr. Bale and Dr. Doneen. I found Robert Walker and Kay MacArthur, all of these people who are teaching at this level where it's understood that we all need each other to practice and co-manage our patients to keep everyone at their optimum level of health. You can't be healthy if your mouth isn't healthy. So I finally found that science that I had been looking for all this time. And when I understood this particular theory, it changed my entire practice. And that's what I really want hygienists to understand, that there's so much clinical, practical information within the research. If we just seek it out and seek to understand and find our tribe, find those people who are studying the same things and take those courses, it's unbelievable how much I've learned that I actually put into my clinical practice and talk to my patients about. And my patients ask me now, well, have you been to any new courses lately? Because I'm always saying, so I was just at this course and what I learned, and this is how it pertains to you, and let's tweak this, and you're going to be so much healthier because of it. So they know what a nerd I am, and thankfully they appreciate that. And it really does come off the page and into clinical practice. You can use this information. It's not just a science for the sake of science. This really will affect your patients and your clinical practice. And for me, after 30 some years, I think it's 34 years now that I've been practicing, I'm not burned out. I'm the farthest thing from burned out. It may hurt a little bit more, but I love it. And I'm so excited to be able to contribute to my patients in such a big way. This is so much bigger than the calculus on the lower anteriors.
Oh, girl, yes, that's the truth. Where the problem is bigger than a scaler to a tooth, and we're not going to accomplish health in our patients just by scaling teeth. Like, it's a much bigger conversation and sometimes treatment for our patients.
It is. It's so much bigger. And the great thing about practicing now is that we have technology that enables us to talk to our patients and enables our patients to see and understand just what we're really talking about. I tell my clients all the time, we used to use the x-rays and we would show them their full series of x-rays, and people don't know how to read x-rays. That's really hard for the lay public to understand. And my patients are always saying, well, those look like toes, and they just don't really see what we see. Yeah. And we show patients, a perio chart. Well, that's crazy too. Very difficult for people to understand, even though we explain it. And thankfully, we got intraoral cameras, so they do understand pictures. And we use the photographs all the time to show the inflammation in the gums, to show a periodontal probe falling deep into a pocket, and they begin to understand that. But now we have even better technology. And actually, this is funny, I say now, I had an electron skinning microscope in my practice in the 80s.
Oh, wow. Whoa.
And it was very cool, a phase contrast microscope. And that went out of favor. We used to do the Kai's technique and show our patients their plaque swimming around. And that was very motivating to see the bacteria in the plaque. And they would actually ask us for treatment. Then it went out of style to have a microscope. And now practices are getting microscopes again. It makes all the difference in the world. I'm now super jealous of my friends who have them because my current practice doesn't. So that's something that I'm saving up for, because it makes such a difference for people to see the bacteria. But what I do have that also makes a huge difference is that I do pathogen testing. And patients understand lab tests. They understand bacteria. They've had many swabs for strep throat or other types of illnesses in their past. And so they understand, okay, I need to take a sample and send this to the lab. And when we get it back from the lab, we'll go over a report. That makes perfect sense to people. And then when you go over the report with patients, nowadays, the reports have been updated. So I use MicroBlink DX and I use Oral ID. And not Oral ID, sorry, that's my fluorescence device for cancer, Oral DNA. And so those are two great tests. There are other tests out there as well. They're wonderful because we can actually look at the specific bacteria that are in our patients' mouths and target treatment to those specific bacteria. And when you sit side by side with a patient and go over lab tests like that, it may not be quite as dramatic as when they see the spirochete spinning on a slide, which I love the combination of the two. But even if you don't have a microscope, you can do a lab test and show your patient exactly which bacteria are in their mouth. Not only talk to them about the fact that maybe that bacteria is associated with refractory periodontal disease, and maybe this is the exact reason that we keep having to retreat, that it's really not their fault. It's not about the fact that they're not accessing these areas well enough with dental floss. It's way bigger than that. First of all, floss can't reach these areas, and we need other devices interdentally. That's a whole nother conversation.
This would really round out the series if I say it on every single podcast episode, that I don't understand why we gave floss such magical powers. Like it's as if it's Superman of oral health. It is not. It is not. There's so much more to it. And you're right. Like we have to really change our message around the home care side of it. I also, I keep thinking when I hear Katrina and Amber Auger that was on and I just don't understand why this type of practice isn't a standard of care for perio practices. I don't hear that as often in perio practices, or am I just missing it?
No, you're right. Recently, I was consulting in a perio practice, and I thought, well, gosh, my big focus has been general practices and how to bring them up to the level of a periodontal practice. That the whole focus on the bigger picture, and I assumed that that's how periodontal practices were run. And then I was called in to consult, and I thought, gosh, what can they learn from me? So I went in to have some discovery about what they were already doing, and they were doing none of this. I was blown away. So they're still practicing, they were using an oral irrigator for their patients. So that was a definite step in the right direction. However, they were not talking about other interdental implements, which are so important. They were not talking about the connection between specific pathogens and specific diseases because they weren't testing for them. And so we had to start back with, guess what, folks? There's a new model of periodontal disease. And so I taught that to this team, and I thought, gosh, I wonder how many other perio practices are not aware. And sure enough, they're not. So we have to realize that the dental hygienists who are practicing in perio practices went to school with us. There wasn't another graduate level like there is for periodontists. They have a graduate level beyond dental school. So we would hope that they would know this and practice on this level. However, it's not necessarily the case. But I will say those hygienists need to avail themselves, just like general practice hygienists do, of the education and the research that is out there. And they're not different from us. Those hygienists that work in perio practices are us. We're all educated the same way in dental hygiene school. And depending on when we graduated, we have a certain level of knowledge. And then it's incumbent upon us to pursue more and more education as we practice in order to stay current. And that's an individual decision, whether they do or not. And some of those people who do not are practicing in perio practices, just like some who do not are in general practices or in pedo practices. And on that note, children are just as susceptible to these diseases as adults, depending on their genetics and on their environment. And we have to treat them the same way. Bleeding gums in a child is also a major problem. Airway issues in children is an enormous problem. So we have to look at the whole child just as we look at the whole adult. We could have so many interviews, Michelle. There are so many topics to discuss when we're talking about being a wellness hygienist. So I'm getting off the path just a little bit, but you're absolutely right that all of us, whether we're in general practice or a perio practice, we need to be current. We need to stay up to date on our education. We need to look at our patients as a much bigger picture than we were taught years ago in school when I was in school. That's the exciting thing, is if you avail yourself of that education and use the new technology, you can be a healthcare practitioner in the biggest sense of the word, because we're talking about, I'm not just a dental hygienist. And it's kind of sad that we have that title, because I feel like the title sounds limiting, and some of us believe those limits, where others of us know that we are very critical healthcare practitioners, and we have a very big role to step into. We have a responsibility to do that. And I think it's a huge opportunity to make a difference.
Man, you just said something that I don't think we've ever touched on is if we believe in our parameters. Are we hindered because we believe that we are just hygienists, or we are just in this little box that we have to practice in? And man, that's powerful. If you believe in more, if you see that there's more, you'll do more. You'll treat better. You'll progress and you'll evolve.
Exactly. And I've had clients tell me I'm just a hygienist, and it makes my head explode. No, you're so much more. We have so much opportunity. And unlike other healthcare practitioners, we have the luxury of time with our patients. Typically physicians have different studies, say different amounts, 7 seconds, 9 seconds, 12 seconds, to hear their patient's complaint and to provide a solution. Seconds, we have some of us an hour for each patient. So that hour could be put to so much use in understanding our patients' whole health needs and how their oral health could impact that and what we could really do for them. So it's so much bigger than, I see you have inflamed gums. You could potentially lose your teeth one day. Now it's like, I see you have inflamed gums. You could have a heart attack, a stroke. You're on the road to dementia. If you're of childbearing age, you may have erectile dysfunction, Mr. Smith, or you may have a preterm low weight birth or a stillbirth. There are so many things that we could impact. And to me, it's really exciting. So it is our responsibility. It's just like I talked about, I did a webinar the other day about head and neck cancers, and that's our cancer. That's our responsibility. Well, I feel just as strongly about periodontal disease. That's our disease. And the fact that it impacts the entire health of our patients is our responsibility and our opportunity to save lives in the dental office. So we need to step into this identity that we are healthcare practitioners, every bit as well educated and as important as any other healthcare practitioner. And if we don't feel well educated enough, the opportunity is out there. And I'm telling you, it is a world of information, and there's more and more research being published all the time. I love the fact that we can take that research and use it in our clinical practice and gain confidence from the more we learn, the more we know, how we can look at our patients and see something so different than we saw the last time we saw them. To me, it's super exciting.
Yeah. I mean, I love that. And I'm also really loving the technology and the information that we can get from that. So I'm curious, like, you don't have the microscope, but that's a possibility. What other technology are you using to help diagnose the issue or treat?
Well, I like to use intraoral camera quite a bit. I like to use the salivary diagnostics. That's my main tool. Of course, simple things, periodontal probing. My goodness, I go into clients' offices all the time and they're not probing, or they're not probing properly, or they might be probing, but not regularly on any type of a routine basis. And they're only charting pocket depth. They're not charting all of the other parameters that are so critical in knowing whether this disease has progressed or not. That's a whole nother thing. It's something that we were all taught in school, just like pre-rinsing. This is not new that suddenly everyone's focused on pre-rinsing, but we were taught this in school, and somehow it goes by the wayside. And I think typically it's because people say they don't have enough time. So in my practice and for my clients, we do periodontal charting for every patient every year. We do periodontal patients every time we see them. So they get a complete charting every 3 months if we see them every 3 months. And there's a reason for that. It's critical to be able to monitor their health. And if we see bleeding, then we test. And if we do a test and we find that the test says there's a low level of PGE and they don't recommend treatment, we ignore that recommendation, because we know that it doesn't matter what the level is. When you have a Keystone pathogen, or really probably any of the red complex, like I mentioned, we treat, because we know at low levels that Keystone pathogen, PG, can alter the gene expression of the other bacteria, and it can impair host response. So there's urgency there. So we really use our heads. We really study and we learn and we use our clinical judgment to know when to treat a patient, how to treat a patient, and move forward very confidently. And that gives your patients confidence, I will say. Sometimes my clients say that, I can't talk to my patient about their cardiovascular disease because I'm just a hygienist, or they don't understand the connection between bleeding and heart attacks, or bleeding and pregnancy complications, or bleeding and cancer, esophageal cancer, whichever. There's, I think, 7 cancers now that we know that are related to periodontal pathogens. Well, of course, your patients don't understand that. That's your job. So we talk about ways to explain that to our patients and to use these technologies. And of course, laser technology is great as far as treatment goes. There are, another technology is the intraoral camera that can show the difference between healthy gums and inflamed gums. I think that's the GoPro. There are so many things that we can do. And there's so many treatments that are beyond most people's scope that we think are just normal, like probiotics, if we're recommending antimicrobials, and probiotics, even if we're not, even just to get that bacterial flora in balance. There are just so many things beyond scaling teeth and talking to patients about flossing. We're so far beyond that. And to me, that's how you make your career exciting. That's how you get up in the morning and you look forward to all the different patients on your schedule. It is not a pick and polish type of day for me ever, and I don't wish that for anybody. So part of my excitement when I coach teams is that you are going to love your job so much more. You're going to be so much more excited, like I am, because everything opens up when you learn how to use this technology, and when you learn how you can make such a difference. And when you have patients coming back and they say, I no longer need my diabetes medication. And, and thank you for finding my husband's high blood pressure. All of those types of reinforcements. I recently had a patient who sent me these gorgeous flowers because I recognized his airway challenges and encouraged him to get a sleep study. And then he got a CPAP. And suddenly, instead of having multiple cups of coffee at work to try to stay awake, and he would have to call his wife on the way home to not fall asleep in the car, suddenly he could sleep well because he was breathing well, and he felt like a new man. And I received this gorgeous bouquet of flowers with a really special note. Now, when those things happen, what could be better? What could be more motivating to keep learning and keep talking to your patients this way and keep saving lives and changing lives? That's how you avoid burnout. That's how you grow as a professional and just put the science into practice. I'm telling you, if you need help with it one-on-one, if anybody out there, call me and I'll help you, because this is the way we grow as clinicians and as a profession.
So I would love for you to walk me through a patient. So if they're sitting in your chair, you notice some bleeding, what are the tests? What are the technology? What is your protocol? What would your next steps be so that we can, because I think, gosh, you're just so motivating. And I'm like, yeah, I am on board now, but what are my practical tips and how do I actually implement this?
Okay, so it's even a step back from noticing the bleeding. We would have gone through their health history, and I would have made note of all of the potential risks that could be connected to oral disease. So if my patient has rheumatoid arthritis, or if they have a family history of cardiovascular disease, or a family history or a personal history of diabetes, or if they have polycystic ovarian syndrome, there are so many different things that are connected either very closely or remotely with periodontal disease. So I would have made a note of all the things that could be connected, a mental note. Then when I do the examination, if I see bleeding, then I can stop and say, I'm concerned because I see this area of inflammation. And what I know is that if your mouth is inflamed, your body is inflamed. If your body is inflamed, that means that the pathogens in your mouth, the bacteria in your mouth, can be affecting remote parts of your body. So let's say, for example, my patient listed that they have acid reflux on their health history, and I see inflammation in the mouth, and I may see other things like erosion on the teeth from the acid coming back up into the mouth. I'm going to talk to that patient about the fact that they have an increased risk for esophageal cancer. And so that already is a big eye opener for people. They may know they have an increased risk for esophageal cancer because they have GERD, but they may not know there's also an oral connection with oral bacteria. And sometimes the oral bacteria are more of a risk than what they realize. So, for example, I talked earlier in the week about oral cancer. Well, periodontal pathogens like PG and Fusobacterium nucleatum are actually more of a risk for oral cancer than smoking. So there are some real eye-opening facts that we can talk to our patients about. So if they have oral bacteria, they're 50% more likely to have a heart attack than if they have healthy gums. There are things that people have no idea of. And if we can have a couple of interesting facts like that, a couple of eye-opening facts that will make our patients sit up and listen, it really does help foster the idea in their minds that we really know what we're talking about. So 90% of the people, probably really higher than that, it might be 93 or even higher now, who have Alzheimer's disease have oral pathogens in the samples that are taken from the brains of people with Alzheimer's disease, over 90%. So this is a real factor. So then I would talk to my patient about the fact that their mouth is inflamed, their body is inflamed. And if we can reduce the inflammation in their mouth, we can reduce the inflammation in their body. And I call it cooling it off because that's how Dr. Bale and Dr. Doneen talk about it. The inflammation is really hot and our bodies are on fire from inflammation. And if we can cool things down, then we can reduce the risk. So we talk about how can we cool things down? Well, there's lots of different ways. Overall, we can talk about diet and exercise. And very specifically, we can talk about what we can do orally. So we can do periodontal therapy, typically non-surgical therapy. I don't want to do non-surgical therapy without a test to find out which pathogens are at play here and if we need to do any site-specific antimicrobials to target those bacteria. There are some cases where we may do a test and choose not to use systemic antibiotics because we don't want to contribute to antimicrobial resistance, antibiotic resistance. But there are other agents that we can use. We still want to know who we're fighting and what the specific risks are. So especially for me, those bacteria that have to do with aggressive periodontal disease or those that have to do with refractory periodontal disease, it's so important to know that because with aggressive, of course, we have tremendous urgency. I personally feel urgency with any bacteria, any pathogens. But with refractory, then we can also have the conversation with our patients. This is why we have not been successful long-term. We may have had short-term success and started to celebrate, oh, you look so much better this time. And then 6 months later, 3 months later, oh my goodness, we're seeing bleeding again. Well, now we know it's because you've been inoculated with these really virulent pathogens, and we have to address that. This is a bigger picture than just cleaning deposits out of a pocket. These pathogens are within the tissues, and some of them are spirochetes. And if we think about spirochetes, when I'm talking to patients, I'll tell them those are bacteria that we also see in Lyme disease. And if you've ever known anybody with Lyme disease, those people have to be treated with multiple different courses of different antibiotics because we're trying to target those bacteria and they go dormant in the presence of antibiotics. And so we have to have what's called a pulsed dosed approach. So we have a whole system attacking those bacteria as they sort of become active again once that initial antibiotic is out of the system. And then we surprise them with another one and surprise them with another one as more bacteria become active. It's a crazy, difficult type of disease to treat. Well, this is the same with periodontal disease when we're talking about spirochetes. We also see spirochetes in Alzheimer's and dementia. When you can connect the oral condition with these systemic conditions that patients have some familiarity with or some anxiety about, it really makes a difference. So if you were to talk to me about Alzheimer's and dementia and my risk there, I'm all ears. I'm listening because I have a family history there. That's why that health history review is so important at the beginning. So once you do see bleeding, then you connect it back to that person's individual risks. So I would talk about that and I would say, here are my recommendations. Let's do some testing and find out which bacteria we're dealing with. And then the test is very simple. So either with oral DNA, for example, it's a salivary swish and gargle. and spit that out, and we send it off. With MicroLink DX, we have little paper points that we can put into specific pockets. We can also drag those paper points across the circumvallate papilla at the back of the tongue, across the tonsil, if your patient can allow you to do that, and get some of those pathogens that we know are present in some of those harder to reach areas in the mouth, and not everything congregates in the pocket. So we send that test off, and a few days later, we have our results online. We can print those off in color for our patients. We bring our patients back for their periodontal therapy. And the first thing we do is go over the results. So we show them what we found. We talk about the connection between the oral bacteria and the oral disease that we're seeing. So whether we're seeing a big change from the last time we saw them, whether we're seeing this constant refractory disease happening, we can talk about exactly why that's happening and what we can do about it. And then we have the conversation about the connection between the oral pathogens and their systemic risk. So it used to be that I would have to bring in a chart that I made for my clients. I would laminate these charts to have in the treatment rooms that would say, if you have on your test result, if you have PG, these are the systemic conditions you can talk to your patient about. If you have FN, this is what you talk about. So I went through all of the bacteria that these tests cover and what the systemic connections are. Well, finally, those companies have now put the connections on the report. So it couldn't be any easier. So you don't have to be such a nerd, and you don't have to understand and memorize all of the connections between the bacteria. That, I think, stressed out some people back at the beginning. But now it's right there on the report. So on one side, you'll be talking about the oral conditions that you see, and you can flip it over, and there it is for the patient. You can walk through it with them about the connections between the bacteria that are found on their test and the risk factors that they have systemically. So we talk about that, and then we talk about which way we're going to go with treatment. And we've already laid out the periodontal therapy that we're going to do and that they're scheduled for, but what additional treatment we will do. So we've probably already talked about lasers, but this is a conversation about antimicrobials. Are we going to do systemic antibiotics? Are we going to do other antimicrobials, like rinses? Are we going to do subgingival site-specific antibiotics? How are we going to address this in the case of these specific bacteria that we find in their test? So once we work that out, then we go forward with their periodontal therapy. I like to do wound care therapy, which is just a little bit different philosophy, meaning that we treat the entire mouth over and over. And that's based on diabetic wound care that a doctor in West Texas, actually, Randall Wolcott, is very famous for saving the most limbs from amputation of diabetic patients than anyone in the world. And so I read up about him, and it's easy to implement this in periodontal therapy because he found those diabetic wounds are covered in biofilms. And so periodontal wounds are the same way. It's all a biofilm disease. And so when we do our therapy, we talk to our patients about multiple appointments, depending on their case, of cleaning the entire mouth and then applying some type of antimicrobial and using products like xylitol to make sure that those biofilms are not adhesive. And we do this over and over. And at the same time, they begin taking systemic antibiotics if that's the course that we go. It's not very common these days for us. And we start using antimicrobials, and we adjust their self-care, and they're using a hydrofloss or some type of oral irrigator. They're using my favorite Tepe interdental cleaners and brushes. They're using all different things than they've used before. And it's a multi-pronged approach to a multifactorial disease. So we tend to get very, very good results. And this is how I talk to my patients about it, and that we'll see them at very short intervals initially, and then we'll retest when our treatment is finished. So for me, treatment is finished when we get to the first maintenance visit. So it's approximately 3 months. So they have a very specific role to play in the treatment. So I'm doing active therapy, and then they take over and they do active therapy at home. So they have we're partners in this. It's not just my job to treat their periodontal disease. So they do their part. And then when that part is finished, that first milestone comes along, when it's time for periodontal maintenance, we take another test. And I usually schedule them a week or two out from their periodontal maintenance visit. They come by for a very quick moment. We take another test, send it off to the lab, so that by the time they come for their maintenance visit a week or two later, we have the results again. And then we go over the results and we see how we did. And typically, the bacteria are much, much lower, if not eradicated. But sometimes, because we've targeted certain bacteria, others will proliferate. We've changed the balance in that microflora. So then we have to address the others. It may not mean more active therapy. It may mean a different probiotic, or it may be that there are some sites that didn't heal that we do need to treat as well. So I use that test to really determine where we are in our process. And if we are at a great balance with no more pathogens present, then we can go into maintenance. But my patients know at the outset that if there are pathogens in that red category, especially, and a few of the orange like FN, then we will be doing more treatment until we can get to homeostasis, a really nice balanced ecosystem for them. And it's all about balance. We don't want to maintain at a level of just obliterating all of the bacteria, because that's not healthy either. But we want to repopulate with healthful bacteria. And that's why we talk about probiotics, especially. That's probably how I explain it to my patients, with a few diversions and offshoots. I never can seem to stay just on one linear conversation.
Yeah,
But that's
because
mostly what it would sound like.
It's not easy. I mean, everyone digresses in a different way, depending on their host response and their pathogens. And even from a clinician standpoint, I've mentioned this on a few other podcasts, but it depends on like what equipment you have. So if you don't have the microscopes, you don't have the ability to start implementing testing at the moment, like I have airflow, you might have, an ultrasonic, lasers, all that. It depends on our equipment that we have currently in our practice and within our scope of practice, because I can't use lasers. South Carolina do better. So, but maybe one day, one thing that I think we keep taking back away from these perio, and Amber actually did mentioned this, because some people are like, I can't do this. This is not going to fly in my practice. Like, how am I going to implement this? You're saying that I got to do these testing. I'm not even scaling teeth yet. And I got people putting, my front office is putting them on my schedule at appointment 1 to do a scaling. And if I don't do that, then I'm kind of getting reamed out for it. But Amber made a good point that, like, if you have the science and you have the business side of it, or you understand where this is going to bring better health and also a profit to the practice in a way, ask for 90 days, test it out for 90 days. Like, just give me some time to do this in my op and with these patients, and see if we can make a difference and we can really make some changes in how we approach this disease.
Exactly. That's exactly how I did it in my practice. I said, I've been dying to do this. Give me a chance. And that's the next thing I'm going to do with the airflow. I just have been dying to get that technology. And I think that's the wave of the future, actually, that subgingival airflow is amazing, and it will change the whole way that we practice and the whole order that we do things with guided biofilm therapy and the whole thing. But that's the way to do it. And talk to your team about, this is the wave of the future. And the future's now. This is what is being done. This is the standard of care. Mm-hmm. And we need to elevate our standards. And I find that so often when I go into practices, or even just talking to people at dental meetings, they say, our office manager won't let us do this. Well, no disrespect intended, but they're not the scientists in the practice. So we have to bring the science and show why it's so important. And we also have to have that business owner's hat too, and understand that we have to monetize what we do. So we get very altruistic, and I'm so guilty of it. We're all about saving lives. We're all about optimum health for our patients, and we'll do whatever it takes. And, by the way, I guess we do have to charge for this, but we do have to think about, this is a business within this business. And so it does have to be profitable in order for us to be able to continue taking care of people. So bring the science and bring the business end of how we can make this a benefit to the practice. So it should be a win for everyone. It should be a big win for the patients. It will be a big win as a clinician to be able to practice this way. And by the way, our practice will benefit as well. We'll be healthier practice. And sometimes we need more time to accomplish that. And team members who are used to scheduling a certain way will have to adjust. And when we make them understand the benefits, then it's a little bit easier to get over that. And once they see it's working, in those 90 days, then it's on us to show how it really makes a difference. And we can do that. I'm a big fan of Amber's too, by the way. Amber and Katrina, you have such great guests, all the best people.
Truly, I would second that very much, that I am just blown away. And we say this all the time on the podcast, and you've been a listener for a while, but we've said it,
Yes.
we're so lucky for the people that come on and spread their knowledge for us. I mean, they just bleed their content, they bleed their expertise to make us smarter, better, more efficient clinicians. And you do it for free because, this is a free podcast and we're not making anybody pay for it. So we appreciate everyone, especially you, Kathryn, like coming on and making us more aware and guiding us along this journey to be oral health wellness coaches and whatever we end up calling ourselves one day, because I would love to move away from hygiene, but like oral health nurses or something. I don't know what we're going to be, but we can't tout that we are preventionists if we're not trying to be preventionists, and we're just chasing our tail, trying to follow those bleeding points, appointment after appointment after appointment. It's time to make some changes and really lean into the idea that we can prevent not just oral diseases, not just loss of tooth structure because of decay, loss of, bone structure and just in the jaw, but for a whole body. We can really control what happens for the health of that patient overall, which is amazing. So
it really is.
Again, so much for your time. And also, I would love for you to tell everyone where they can find more of you, more of your content. I joked with Amber, I don't know when we'll ever be in person to speak again, but if that happens, where can people find more, even webinars or information so they can continue to learn from you?
I do hope we can get together in person again. I miss that so much. I live for my dental meetings. But in the meantime, you can find me on Facebook at www.facebook.com/PerioLinks. And you can find my website, which is also www.PerioLinks.com. And I do have on my media page, I have links to my webinars, most of the webinars that I've done, and some podcasts, and did a really cool podcast in Australia a couple months ago. And that was really fun to think about extending my reach. So that was very exciting. I'm out there in the world sharing information. In fact, later today, I'm talking to a hygienist from Italy. And I had a conversation the other day with a hygienist in the Netherlands. And it's so cool that all of the hygienists around the world that I'm talking to are dying for more information. So I'm happy to share, yes, this is a free podcast. Yes, I'm thrilled to do it. That's how we are. That's how we are with our patients. That's how we are with our colleagues. Whatever I know, I'm happy to share, because what it means is that more of us will love what we do. More of us will save more lives. And what could be better?
Love it.
So look for me on social media. Thank you so much for having me.
Of course. Definitely check out Kathryn, find her on Facebook, check out her website, and go listen to some of her webinars. I have no doubt you'll be just blown away. And if you have questions, send them in, because maybe we can bring Kathryn back on to do like a Facebook Live or something with us, and we can answer those questions in real time. I think that'd be fun as well. So thank you again, Kathryn. You're the best.
Oh, thanks, Michelle. I've been a stalker of yours for a long, long time, as you know. I'm a fan. Thanks so much for having me.
Kathryn is probably the sweetest soul. What a good, loving, kind-hearted person.
We're so lucky.
When you just meet those people and they're just like, you're good. You're good. Your aura, I don't know what you would call it, but you're good. You're good.
Good in my book.
She's good. And she cares. She truly cares. And she really is always like striving to learn more and teach more. She's fantastic. So I hope you guys enjoyed this Perio series that took us 5 years to come.
The culmination of 5 years of work finally is getting.
Finally. But it was fantastic. So we really thank you for listening to another great episode. And I hope you enjoyed our rant in the beginning or our funny part of Andrew and his zit. And
excellent. Thanks for bringing that back up at the end of the episode.
And also that he said
people thought that they were going to forget how moist it got underneath my mask. And now they're not going to be able to.
Oh, I was waiting for the flappy part, and I was going to be like, I don't know how you're bringing this in.
I was inhaling, exhaling, and how it flap against my skin, how flappy that mask is, but it wasn't true. Can I also say, though, one thing I did forget to say is I'm very grateful for the dental assistant in my office who purchased ahead of time those extenders for the loops on your face masks.
Ooh.
And so, and I don't have a link necessarily for those ones, but you can, I'm sure, Google them. It's just an extender. So I was able to actually put the weight of both of the masks on the back of my head rather than on my ears. And so it felt really tight on a couple of them, but it was tightness on the back of my head instead. And so I did end up having those big the crease lines that go from my nose over my cheekbones, down over my cheeks, and then underneath my chin. But that was a small price to pay.
Your little ears?
My ginormous Dumbo ears.
They were saved.
They were absolutely saved. And it was because the first time I had them, I tried it without it, and my ears were bent forward. It was really uncomfortable after that hour, and it was just a nightmare. So
yeah,
look those up.
Well, I'm really thankful for the assistant who was helping me also. As I was garbing up, I couldn't find my ear to put the ear loop over, like I was like, where is it on? Is it on? And she's like, no.
Oh, that's excellent.
So I'm really, let's also I would love to give a nice little shout out to the amazing dental assistants out there.
Absolutely.
Rocking it. There's two I've worked with in my career that I would follow them to an office because they were just super easy to work with. I was excited to work with them, you know, like, you know, there's people in your life, like, I don't know, my very first one, Heather, I know she's not listening to it, but she and I worked food and bev at separate times at the same restaurant. And we just had this like rhythm about setting up and like, I don't know, it was so great. And I don't know if it was exactly food and bev, but we just had a great rhythm. And then like Olga, she was always like, willing to learn. Like anytime I was done with the book, she was like, oh, can I read that? Like, I heard you say this to a patient. Can I read that? And I'm like, and she taught me Spanish, like not good Spanish. Like I speak very little dental Spanish. Let's not think that I'm great at this. Let's not get anyone. I'm not great at Spanish, but I can speak a little dental Spanish and I'm really grateful for her. And I always trusted them. I was super reliant on them. And when they both, I left one and the other left me and I'm like, oh my. Don't leave me. So thanks, amazing assistants out there. You're great. You're awesome. We love you.
That's true.
Well, this has been fun. Really great Perio series that we're wrapping up. And if you guys have any questions, be sure to follow us on Instagram or Facebook. You can direct message us there. And you can also send us a message at our website at Tale of Two Hygienists. And if you want to talk to me or Andrew, you can just do Michelle or Andrew at A Tale of Two Hygienists. Remember, there's an S on the end.com. And we would love to hear from you. And please, 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 we always appreciate your rating and review of this podcast. And you can go check out our show notes because I have a super simple link you can click and leave us a review. It's so appreciated. It's how people help find us. It tells Apple, you know, that we actually are doing the thing. You're doing the thing that we like to do and we're doing it well. And so we'd appreciate that. Anything?
That's it. I hope everyone has a great week.
Awesome. Bye, y'all.
Keep it moist and flappy.